In this presentation, we will review the image analysis of the common hand projections PA, oblique, and lateral. We will also review image analysis guidelines, common positioning errors, and ways to take corrective action. Let's begin with the PA hand projection. Image analysis guidelines for the PA hand projection state that the soft tissue outlines of the 2nd through 5th phalanges should be symmetric. Distances between the metacarpal heads is equal. Equal midshaft concavity is seen on both sides of the phalanges and the metacarpals of the 2nd through 5th fingers. The thumb demonstrates a 45-degree PA oblique in this projection. There is no soft tissue overlap from the adjacent fingers. The thumb is in close proximity to the hand. The IP, the MCP, and the carpometacarpal joints are demonstrated as open. The phalanges are demonstrated without foreshortening. The 3rd metacarpal joint is at the center of the exposure field, and the phalanges, metacarpals, carpals, and 1 inch of the distal radius and ulna should all be included within the exposure field. Here are those image analysis guidelines for your review. So let's discuss some common positioning errors that occur during hand radiography. We're going to focus on the external rotation, internal rotation, and proper thumb and finger separation. So the first image here is an example of a PA projection positioning error where the hand is in external hand rotation. When the hand is not fully extended and brought flat against the IR, but remains slightly flexed, external rotation is likely to occur. This leads to a narrowing or even slight superimposition of the 3rd through 5th metacarpal heads. Also, this results in unequal soft tissue thickness, and mid-shaft concavity can be seen along the sides of the phalanges. The metacarpals themselves will also display uneven mid-shaft concavity and inconsistent spacing. Now, I do not have an example of internal hand rotation. However, this is rarely a concern because the thumb naturally limits that inward movement. So it's just worth noting that it's very unlikely a cause of a positioning error. Lastly, let's talk about proper thumb and finger separation. Proper separation of the digits is crucial. Keeping the fingers close together without overlapping the soft tissues ensures clear visualization of each digit while allowing for tighter collimation. And this is going to improve your resolution. We're at our first practice analysis. Please review the image and answer the following question. Let's conduct this practice analysis together. In this PA hand projection, I'm first going to determine, do I have all my anatomic structures? In this case, we do have our anatomy within the projection. However, now we need to determine whether our positioning is adequate. For the PA hand projection, I see that there is some joint spaces in the phalanges that are closed. This is a positioning error. We also should look for any foreshortening or unevenness in the midshaft concavity of the phalanges and the metacarpals, and there is some. In addition, when you look to the proximal portion of the radius and ulna, we almost clip the joint here. So we might need to open up our collimation or realign your central ray, depended on where the central ray was placed. In this case, we should open up the collimation a little distally by 1/2 inch just to include that 1 inch of the distal forearm. Also, when we take the repeat imaging, you want to internally rotate the hand so that the hand is placed with the palm flat and the fingers fully extended to open up those joint spaces. Take a moment to review this image and answer the following question. So let's review this practice analysis together. In this PA hand projection, again, you want to determine whether you have all your anatomic structures. In this case, we do have our anatomic structures. However, are they adequately visualized for the PA hand projection? In this case, we do not. They are not adequately visualized. Our IP and carpo-metacarpal joints are closed. Our phalanges, distal phalanges and metacarpals are foreshortened. And the thumb was in a lateral projection when it really should be more in a oblique projection. The hand and fingers are flexed in this image. How do we take the corrective action? We want to place the hand flat against the IR and fully extend those digits so that we can get our joint spaces open and decrease that foreshortening of the phalanges. There are some cases that the patient may not be able to extend the fingers. This may require use of an AP projection, adjusting for optimal visualization without foreshortening of those digits. This is usually used in a worst case scenario. So let's move on to the PA hand oblique projection. Image analysis guidelines for the PA oblique projection state that each of the 2nd through 5th metacarpal midshafts demonstrate more concavity on one side than on the other. 1st and 2nd metacarpal heads are not superimposed. The 3rd through 5th metacarpal heads are slightly superimposed, and only a space is present between the 4th and 5th metacarpal midshafts. There is no soft tissue overlap from the adjacent fingers. The thumb should be in close proximity to the hand. The IP and MCP joints should be demonstrated as open. The phalanges are demonstrated without foreshortening. The thumb will be in a PA oblique projection. The 3rd metacarpal joint is at the center of the exposure field. Distal phalanges, metacarpals, carpals, and 1 inch of the distal radius and ulna are all to be included within the exposure field. Here's those image analysis guidelines for your review. So let's take a look at the effects of insufficient hand obliquity and excessive hand obliquity. An insufficient hand obliquity, it occurs when the hand is rotated less than that required 45 degrees. In this case, the metacarpal relationships begin to resemble those seen on a PA hand projection. Specifically, the midshafts of the metacarpals appear more evenly spaced. and there's little to no superimposition of the metacarpal heads. This in turn, the lack of obliquity compromises your diagnostic quality. On the other hand, excessive hand obliquity happens when the hand is rotated more than that 45 degrees. In a properly positioned PA oblique, a small space should be visualized between the 4th and 5th metacarpal midshafts. However, when excessive rotation occurs, the space becomes obscured and the 4th and 5th metacarpal midshafts demonstrate partial superimposition. It's crucial that we should maintain that correct degree of obliquity to achieve the diagnostic image that our Merrill's requires. Please review this first practice analysis and answer the following question. So let's review this practice analysis of this oblique hand. First, you definitely wanted to determine whether you have all your anatomic structures, and we have our digits in full all the way down to the distal radius and ulna. Next, we want to determine are we representing the anatomy appropriately. When analyzing this image, you can tell that there is some overlapping midshafts of the 4th and 5th metacarpals, which indicate that the hand was angled greater than that 45 degrees. Additionally, the phalanges appear foreshortened, and our IP joints are closed. This happens because the fingers were used to prop the hand rather than being extended. To correct these issues, you want to internally rotate the hand until it forms that 45-degree angle with the IR, and you want to ensure that the fingers are fully extended and parallel to the IR to eliminate that foreshortening and allow for those joint spaces to open properly. So let's move on to the fan lateral hand projection. Image analysis guidelines for the lateral hand projection state that the 2nd through 5th metacarpals are superimposed. The 2nd through 5th digits are separated, demonstrating little superimposition of the bony or soft tissue structures. The thumb is demonstrated without superimposition of the other digits and is in a PA to slight PA oblique projection. The IP joints are demonstrated as open. The phalanges are not foreshortened. The thumb is positioned close to the hand. The MCP joints are at the center of the exposure field, and the phalanges, the metacarpals, carpals, and 1 inch of the distal radius and ulna are all included within the exposure field. Here are those image analysis guidelines for your review. So let's discuss some common positioning errors encountered in the fan lateral projection of the hand and how to identify them utilizing metacarpal alignment. In external hand rotation, the midshafts of the metacarpals will not be superimposed, and the 5th metacarpal is seen anterior to the 2nd through 4th metacarpals. The hand will be externally rotated when this occurs. Remember that the 5th metacarpal is the shortest of the 2nd through 5th metacarpals, making it more easily identifiable in this type of error. In internal hand rotation, this occurs when the midshafts of the metacarpals are not superimposed again, and the 2nd metacarpal is demonstrated anterior to the 3rd through 5th metacarpals. The 2nd metacarpal is the longest of the 2nd through 5th metacarpals, and it serves as a key indicator of for this type of positioning error. Remember that maintaining proper alignment of those metacarpals is crucial for achieving the diagnostic quality in the fan lateral projection. Please review this following image here and answer the following question. So let's conduct this practice analysis together. First, you definitely want to evaluate to determine whether or not we have all our anatomic structures that are required. And we do have our distal phalanges too, the radius and ulna included with the image. However, we need to determine whether or not we are adequately demonstrating the anatomy for the projection. In this case, you can see that the mid shafts of the 2nd through 5th metacarpals are not superimposed. And if you look closely, the shortest metacarpal, which is the 5th, appears to be anterior to the 2nd through 4th metacarpals. This should indicate to you that the hand has been externally rotated. To correct this imaging error, you need to internally rotate the hand until the metacarpals are superimposed, ensuring proper alignment for the accurate lateral hand projection. Take a second to review this lateral hand analysis and then complete the next question. So let's work through this practice analysis. Always check to see if you have all your anatomic structures, with which we do. Next, you want to determine whether we are adequately positioned to demonstrate the anatomy required of this projection. In this image, the digits are superimposed with the thumb and the first finger are touching here. The fingers are not properly fanned, which is leaving them somewhat superimposed. The 5th metacarpal is positioned anterior to the 2nd through 5th metacarpals, which tells us that the hand is in slight external rotation. To correct this imaging error, we need to separate the thumb and the first finger, ensuring that they aren't touching. Fan the 2nd through 3rd fingers anteriorly and the 4th and 5th fingers posteriorly. Then we also need to internally rotate the hand until the metacarpals are superimposed for proper alignment. This concludes our image analysis of the hand projections PA, oblique, and lateral. If you have any questions, please feel free to reach out or email me at any time.